of a clue already? This chapter is all about ischemic heart disease. In our last video, we started with the pathological mechanisms that cause a mismatch between myocardial oxygen demand and coronary oxygen supply. And then we went down to the cellular level. We zoomed way in, and we looked at an individual cardiac myocyte, just doing that contraction thing that it do, when all of a sudden, there's just not enough oxygen to go around. We then illustrated the specific cellular changes that occur in the setting of ischemia, as well as the various ways the myocardial cell can respond. In almost every case, the whole reason we even have an oxygen supply-demand mismatch in the first place is because of an atherosclerotic lesion inside one or more coronary arteries. This is called coronary artery disease, or CAD, and it's the main focus of our next sketch. You see that sign up there? That's right. These are the royal stables, my friend. And each one of these horses is worth like 500 florins, or ducatus, Cs, or something. Look, it's a lot, okay? What I really want you to focus on is that sign adorned with our recurring red coronary crown. All of the pathological events we're about to illustrate are going to take place inside the lumen of those coronary arteries, leading to reduced coronary blood flow and an ischemic myocardium. In this scene, when you think of an atheromatous plaque, I want you to think of these plaques mounted above the stables. Later on in our vascular unit, we'll go over the risk factors that predispose your patient to developing these atheromatous plaques in peripheral arteries, such as obesity, smoking, hyperlipidemia. All these same risk factors apply. In your patient with peripheral artery disease, suspect coronary artery disease as well. Here's the thing though, even when they form in the coronary artery, most of these lesions just sit there quietly. I mean, just take a look around. Peaceful, right? Symptoms occur way later. In fact, coronary atherosclerosis usually builds up over decades before causing any major problems. It's building up inside of you and me right now, actually. Can you feel it? I can. This is getting weird. Let's move on. It isn't until a lesion reaches about 70% stenosis that it becomes clinically significant. See how we incorporated the number 70 into the blacksmith's tongs? At this point, patients typically describe a dull, left-sided substernal chest pressure that's worse with exertion and relieved by rest. That's angina, and it's sketchy. All that pain and pressure is embodied by a recurring angina anvil. Again, I want to bring your attention to that plaque up there. It's mounted, fixed, if you will. It's not going anywhere. A fixed obstruction in your coronary artery, if big enough, will cause predictable episodes of angina during periods of exertion. This is called stable angina. The plaque is stable, and the chest pain is predictable. Recall from our last video all those events that increase the heart's oxygen requirements. Each of these can trigger episodes of angina, like valvular stenosis, or exercise, or doing a line of cocaine. Preferably not that last one. You should also remember that the subendocardial zone usually gets ischemic first. That's the innermost layer of myocardial cells. Think of it like this. The coronary arteries have to penetrate deep into the walls of the myocardium. And sometimes, there just isn't enough oxygen reaching that innermost layer. In this scene, that red-hot and excessively oxygenated horseshoe is meant to depict the cross-section of the ventricle. And if you take a close look, you'll see that a cold ischemic spot has formed on that inner surface. Don't worry, with stable angina, this episode of ischemia is only transient and is insufficient to cause myocyte death. There can be pain, though. Take a look at the cool protective gear the blacksmith is wearing. Besides poorly localized chest pressure, patients may feel numbness and pain that radiates down the left arm, or even to the jaw. Other symptoms include dyspnea and diaphoresis. Just think of everything an overexerted blacksmith would feel. A word of caution, though. Older patients, diabetics, and women are more likely to present with only dyspnea and weakness. There could be no chest pain at all. The defining feature of stable angina is that these episodes usually only last for a few minutes to half an hour and are improved with rest or nitroglycerin. So all he has to do is take a break, pop some nitro, and reduce the heart's oxygen demand. Nitro, as always, is symbolized by a box of nitroglycerin dynamite sticks. Check out our Johnny Nitro sketchy farm sketch for the specific mechanisms that underlie nitroglycerin's ability to improve the symptoms of angina. Most importantly, it vasodilates. This reduces venous return and, therefore, preload that sits in the chamber. The heart doesn't have to work so hard, and oxygen demand is reduced. Other medications that are helpful for more long-term management of stable angina include beta blockers and calcium channel blockers. Check them out in our sketchy farm course. Just look for that recurring angina anvil. All right, it's time to talk about that other angina, Prinzmetal angina, also called variant angina. And if you're really cool, you just call it vasospastic angina. And that's because it results from spontaneous, intermittent coronary artery vasospasm, often at rest and more commonly at night. Hence the sleeping stable boy here. Instead of, hey doc, every time I get on the treadmill, it feels like an elephant is sitting on my chest. You'll hear something like, hey doc, I get these recurrent episodes of chest pain. I'm not really doing anything when they happen. It'll even happen at like 2 a.m. and wake me up. Instead of a stable atherosclerotic plaque causing obstruction, the main mechanism here isn't completely understood, but is thought to involve smooth muscle hyperreactivity inside that coronary artery wall. Just think of the stable boy startled awake, hyperreactive. That twisted red sleeve is meant to evoke an image of a spasming coronary artery, causing a transient obstruction and myocardial ischemia. The metal on that horse, by the way, is there to remind you of the name Prinzmetal. This spasm can occur in completely disease-free vessels. You may notice, however, that we've included one of those plaques above the stable door. That's the interesting part. Although spasms can occur in angiographically normal coronary vessels, more commonly, it occurs right over an atherosclerotic plaque. What the? Though the pathogenesis isn't yet fully elucidated, it's probably a result of increased local thromboxane A2 or endothelins. Oh, it's weird. Now, the diagnosis gets a bit complicated because the symptoms are very similar to stable angina. Substernal pain, pressure, dyspnea, diaphoresis, and episodes will even get better with nitro. With stable angina, we were using nitro to decrease preload and myocardial oxygen demand. In the setting of vasospastic angina, on the other hand, nitro helps by relaxing the smooth muscle in that spasming coronary artery. Because of their potent vasodilatory properties, calcium channel blockers are useful as well. In fact, calcium channel blockers such as nifedipine, diltiazem, and verapamil are going to be your first-line therapy for long-term management of vasospastic angina. And nothing says calcium channels quite like a fresh bowl of our recurring calcium ice cream. Check out our farm course for more details. Besides the fact that these pain episodes are usually unprovoked, which really sets it apart from your classic stable angina symptoms, patients with vasospastic angina are often younger and exhibit fewer classic cardiovascular risk factors. There is one big risk factor to watch out for, though: cigarette smoking. And on test day, they'll usually mention some kind of smoking history in the question stem. An optimal treatment strategy includes encouraging your patient to quit. Other classic triggers include sumatriptan, hence the angry sumo stable manager here, who's caught the apprentice sleeping on the job, yet again. Watch out for some pathomimetic agents as well, such as cocaine and amphetamines. They make those coronaries all spazzy and stuff. All right, so far we've been focusing on myocardial ischemia that arises because of a stable occlusive athromatous plaque. What happens if this plaque gets disrupted? The thing to keep in mind here is that athromatous plaques are not stationary structures. Quite the opposite, actually. Think of them as bubbling, lipid-filled cauldrons, constantly churning. A dynamic process of intimal thickening, fibrous cap formation, remodeling, and possibly plaque rupture. Or in this case, horses rupturing out of their stables. Now, when I say ruptured plaque, I don't want you to think of a bunch of lipidy goo filling the lumen of the coronary artery. Instead, a fissure opens up, exposing subendothelial collagen, tissue factor, all kinds of prothrombotic substances. This serves as a nidus for thrombus formation. That means platelet adherence and activation, hence the medieval baseball game getting disrupted. We always show platelet activation around home plate. The coagulation pathway is ramped up as well. In this scene, we'll draw in a bunch of thrombotic hay to represent the big, coagulated, thrombotic mess that starts to fill the lumen of the coronary artery. The exact steps of plaque formation and rupture will be covered later in our vascular unit. For now, let's focus on the clinical events that can arise when plaques become unstable. If the thrombus occludes enough of the lumen, it can lead to an episode of myocardial ischemia and infarction. In the vast majority of cases, though, the patient feels nothing. It turns out that plaque disruption and thrombosis is quite common throughout life, and usually it's clinically silent. The healing of these atheromas is actually one of the ways that plaques become bigger over time. It's just another example of how dynamic these plaques really are, rupturing and healing, and progressively growing in size. Yep, rupture is a common occurrence here at the Royal Stables. It's all good, though. The fence is getting repaired as we speak. If the thrombus occludes enough of the lumen, however, an acute episode of myocardial ischemia occurs. This is called an acute coronary syndrome, or ACS. See the brand on that royal horse? ACS is an umbrella term that comprises 3 distinct syndromes: unstable angina, non-ST elevation myocardial infarction, or NSTEMI, and ST elevation myocardial infarction, or STEMI. Let's go through each of these acute coronary syndromes one by one. First of all, notice that the plaque above the stable is toppling over as the horse breaks free. Unlike the athromatous plaques associated with stable angina and vasospastic angina, ACS is caused by destabilized plaques. This involves plaque rupture, plaque erosion, or calcified nodule formation. Either way, prothrombotic surfaces are exposed and a thrombus forms inside the coronary artery lumen. Take a look at all that thrombotic hay. That can't be good. Unfortunately, we can't really predict which plaques are going to cause an acute coronary syndrome like this. Atheromas with thin, fibrous caps are considered vulnerable plaques, but there's no way of measuring this accurately in the patient. Also, numerous other factors are likely at work here, including inflammation and enzyme activation within the plaque prior to rupture. In fact, a high percentage of acute coronary syndromes are attributed to plaque rupture that occurs in lesions with less than 50% diameter stenosis. That means these events are occurring in smaller plaques that aren't even causing any symptoms yet. So there's no way of knowing which one is going to blow. How bad is the ischemia going to be? Well, it all depends on the degree of obstruction caused by the thrombus. Let me show you what I mean. You see that stable boy sweeping all that thrombotic hay? Notice that the lumen of the bucket he's using is only partially filled. That's because acute coronary syndromes can arise even when the thrombus is only partially occlusive. Or, if the entire lumen is occluded, it's only transient. As depicted by this attentive stable sweeper here. Right when a thrombus starts forming, it already begins to be rapidly cleared by the body. Such is the case in unstable angina. This transient or partially occlusive thrombus causes enough obstruction to generate an area of ischemia in the myocardium. The symptoms of unstable angina are very similar to those of stable angina. And, as usual, all that pain and pressure is embodied by our recurring angina anvil. This time, however, the anvil is falling over. It's unstable and unpredictable. The hallmark of unstable angina is an acute worsening of symptoms. These patients will begin to notice the same symptom severity with comparably less exertion, or they'll start to experience angina at rest. Unstable angina warrants immediate workup because prolonged ischemia leads to infarction. That's right, my friends. Time is muscle. That brings us to our next acute coronary syndrome, myocardial infarction, or MI. This usually involves plaque rupture or plaque erosion. Myocardial infarction remains the leading cause of death in adults in the United States, where approximately 1.5 million people suffer an MI every year. 1/3 of them die, half of them before they even reach the hospital. Myocardial infarction comes in two forms, STEMI and NSTEMI. Let's start with NSTEMI, which stands for non-ST elevation myocardial infarction. Just pay attention to that infarction word for now. Instead of myocardial ischemia, which can be reversible when blood flow is restored, we've got infarction, which involves cell death and tissue necrosis. At Sketchy, we use a broken heartstring to evoke an image of myocardial cell death, like the one on this heart-shaped lute, getting trampled by the horse. Just like an unstable angina, the pathogenesis of myocardial infarction involves a ruptured or eroded atherosclerotic plaque with an overlying thrombus. So again, we've included an unstable plaque up there, toppling over as the horse ruptures out of the gate and sends a cascade of thrombotic hay into the lumen. That's because when your ECG comes back, you'll likely see ST segment depressions rather than elevations. These ST changes can be diffuse, but are usually localized to the leads associated with the region of affected myocardium. More on that in the next video. For now, when you think of ST depression, think of a falling ST street sign. STEMI, on the other hand, is the name of a myocardial infarction that causes ST elevations on that ECG. This will be represented by the upright ST street sign. Notice too that we've sketched in another one of those broken heartstrings to remind you that we've now reached the stage of infarction and cell death, not just ischemia. So why would I get an NSTEMI and not a STEMI? Again, it's all about how bad that occlusion is. An NSTEMI is caused by a thrombus that is only partially occlusive. So notice that the lumen of his lute is only partially filled with that thrombotic hay. Or if the entire lumen is occluded, it's only transient. So we've brought back the stable boy, sweeping up that thrombus. This leads to a partial thickness infarct. In other words, it's that innermost layer of the myocardium, the subendocardial layer, that feels the infarct first. See how only a portion of the inner surface of the horseshoe is cold and ischemic? ST depressions on ECG are an indication that only a partial thickness of the myocardium is involved. A STEMI is usually caused by a thrombus that is fully occlusive. Take a look at the lumen of his lute, fully obstructed with that thrombotic hay. Also, these lesions are not as transient. No stable sweeper here to clean up the mess. That thrombus is staying right where it is. This leads to a full thickness infarct. In other words, while that innermost layer of the myocardium, the subendocardial layer, feels the infarct first, leave the occlusion there long enough and it will spread through the entire myocardium. As such, the entire cross-section of the horseshoe is getting doused, cold and ischemic. ST elevations on an ECG, then, are an indication that the entire thickness of the myocardium is involved. This is called a transmural infarct, and a specific sequence of ECG changes can be expected when the entire myocardium is involved like this. We'll go through them briefly. First, you get hyperacute T waves, so we've drawn in a T-shaped weather vane up on the roof. These waves are tall, broad-based, and symmetrical. Take a look. I'm not kidding when I say hyperacute, by the way. They only last for a few minutes. By the time the patient reaches your ER, those hyperacute Ts will probably have already transitioned into those classic tombstone-shaped ST elevations, symbolized by that elevated ST street sign, of course. These ST changes are localized to the ECG leads that correspond to the area of infarcted myocardium. As tissue necrosis progresses, negative Q waves form next, as depicted by the Q shape of that waving lasso. In hours to days, the ST segment gradually returns to baseline, and that Q wave deepens. In addition, the T wave becomes inverted. And that's why we've drawn an inverted T shadow on the ground, cast by that weather vane. So, in summation, hyperacute Ts turn to ST elevations. The Q wave deepens, and the T wave inverts. This is a very simplified view of the ECG changes that occur as the infarct progresses. In reality, variations occur based on the size and location of the infarct. Why is that stable keeper with the Q lasso so gnarly and old, you ask? Pathologic Q waves can persist for a long time. Years, in fact. When they show up on ECG, they may indicate an area where a prior infarct has occurred. So, while those other ECG changes are seen in a more acute to subacute setting, Q waves like to persist, and just kinda hide out in the back of the stable there. All old and crusty, lurking around like Gollum. It's not healthy. One more thing to watch out for, and that's new onset bundle branch block. So, up on the roof, we've drawn a medieval roof thatcher dude. And fittingly, he has a bundle of branches tied to his back. Bundle branch block occurs when the infarcted area involves the conduction system of the heart. Usually this manifests as left bundle branch block, as the left anterior descending artery is the most commonly affected vessel. And that left bundle just doesn't have as much collateral circulation. So an infarct knocks it right out. Alright, every patient who comes in with cardiac complaints is going to immediately get that ECG strapped onto them. It's not just for detecting myocardial infarction. Myocardial ischemia will show up as well. In both stable and unstable angina, for example, you'll likely see some ST depression in the leads that correspond to the area of ischemia. So watch out for that falling ST street sign. Remember, ST depression means that only that inner subendocardial layer is affected. This is where the ischemia starts to do damage first. A little cold ischemic spot right on that inner surface. See? Prinz metal angina will actually show up a bit differently. That transient coronary artery spasm actually leads to a transmural ischemia. The whole thickness of the myocardial wall is usually affected. So instead of ST depression, look for transient ST elevations on that ECG. Alright, let's take a look at the whole scene. Depending on whether we have subendocardial versus transmural ischemia, the ECG will look different. Especially that ST segment. But look over at the unstable anvil on the right there. Unstable angina looks surprisingly similar to NSTEMI in the next all over, right? Both are partial or transient occlusions, both involve the subendocardium, and both will show up as ST depressions on ECG. So, how do I know it's infarction, rather than just ischemia causing angina? It's time to look for cardiac markers. NSTEMI and STEMI cause irreversible cell injury, leading to cell death and tissue necrosis. Myocyte membranes rupture, and they dump a bunch of molecules into the serum. The most sensitive and specific of these that we can measure are troponin and creatine kinase. Troponin will be represented by this troponin T-bone steak here, seared to perfection. Creatine kinase, as always, is symbolized by a bucket of CK crispy chicken. This molecule takes the form of numerous isozymes throughout the body. CKMM is found in skeletal muscle, CKBB is found in brain tissue, CKMB, though, that's the one that's specific to cardiac muscle. Just think of MB for myocardibum. That sounded better in my mind. Ooh, I know. Just think of our usual CK crispy chicken value meal, but this time with more biscuits. Now part of the special medieval value meal, only at CK Chicken. Get ready to enter an Iron Maiden of flavor. There are a couple of troponin isozymes as well, troponin I and troponin T, but it's less important to understand the distinction between them. Briefly, troponin I is more specific for cardiac muscle damage, while troponin T is more sensitive. Sensitive has a T in it, so that's troponin T. What you really need to focus on, though, is the time course over which CKMB and troponins become elevated after myocardial infarction. Let's start with that troponin T-bone steak. Serum troponin levels will be elevated within 4 hours of an MI and peak at 24 hours. So, we've drawn our Gothic grill master here, raising up that troponin T-bone steak right above the 24-hour sign. Not only that, the sign reads 24/7 because troponins peak in 24 hours and usually stay elevated for over 7 days. CKMB, on the other hand, peaks in 16 to 24 hours and returns to baseline at about 48 to 72 hours. So we have two suns here. It rises in 24 hours, peaks, and then sets over the next 24 hours. Overall, while troponin is more specific for signaling cardiac muscle damage than CKMB, CKMB is much more useful at identifying reinfarction within the 7 to 10 days following the initial insult. It returns to baseline much sooner, so if there's any kind of reinfarction, you'll see that CKMB rising yet again. Let this reheated bucket of CK chicken remind you of CKMB's usefulness for assessing reinfarction. In reality, even CKMB takes a little too long when you're acutely managing ischemic events. So remember, ECG is your gold standard diagnostic tool in the first 6 hours of initial infarction. Look for those Q waves, ST changes, and bundle branch blocks.